I'm curious, like how it does work. Like, are your medical oncologists interested in combination? Like, they bring you in specifically because they're like, okay. And so I was curious, like, when do you end up treating these patients? When they're on immunotherapy, when they're on a pause, or
So TACE works. I mean, there are several patients where we're confident that we can achieve a complete response with a TACE, or we see a complete response, and there's sometimes just no reason to really expose the patients to, an additional therapy at this point. Also, I always think about this as kind of a little bit wasting my ammo before they progress or we'll need it down the road, right? And secondly, I think that when we think that a TACE may provide a, partial response or good complete response, but, the AFP is not ideal, or there is some other small extrahepatic disease, so there, I think we combine a lot. And I'm very grateful for having courageous medical oncologists here at Yale who are willing to go for the combination therapies. And sometimes, when there is an indication to start with immunotherapy, then this is started, and then there is, a lesion that did not respond paradoxically as compared to other lesions in the liver, and it needs touching up, right? And then we bring TACE back in. But it's no longer just one versus the other. It's a lot of, really combinations in individual scenarios. But, we're more and more trying to, by consensus, agree upon the combinations when they're needed.
so Richard, this was a scenario that I actually wanted to specifically talk about. In your practice, how often is it that you'll make a referral to IR when you have a patient that's on immunotherapy, 10 lesions, whatever, 9 of the 10 are responding great, but then you have one lesion that's either growing or not responding at all? Like, how do you think about that scenario?
It's not such an uncommon scenario. And whether it's all in the liver or even, they develop an oligometastatic lesion in the adrenal or the lung. This is more common in patients who have been on for a long time, right? They've had some response, some tumor control, and then they have perhaps escape of one lesion, or they develop a portal vein thrombosis, in which case I've engaged the radiation oncologist. But I have referred back to IR because, there's a data gap there now in second-line systemic treatment, right? We have a lot of drugs available, all the drugs that we had before IO, right? Lenvatinib, sorafenib, Rego, Rafenib, cabozantinib, ramucirumab, a lot of drugs available, but how well they work after frontline IO, we don't know. The biggest improvement in the modern age of taking care of people with this disease is from immunotherapy. So if patients are tolerating it, and also compared to all those drugs I just mentioned, outside of ramucirumab, they're not so well tolerated, right? They have side effects that we don't see with IO. Hand-foot skin syndrome, GI toxicity, anorexia. So if a patient's doing really well on IO-based cocktail and their tumor is very well controlled, but they have one lesion that, for lack of a better word, is escaping, I would offer them some procedure with IR at least one time. Give them a chance, because I think that growth of that lesion is either escape or it's just a precursor to more progression that's going to happen in due course. So I don't think there's a role for, picking off 5 or 6 lesions, but, if there's one lesion that escapes, and it also depends on that disease-free interval, right? So you have that lesion treated, but it's different for a lesion that pops up in 2 months versus one that pops up a year later, right? I'm not going to rush and change their systemic treatment. If I would probably send them back to IR.
Julius, anything to add on that, or that mirrors kind of like what your practice is looking like?
Mirrors very much, I think, a state-of-the-art multidisciplinary practice. And we see very similar things here. Yeah, I would agree with Rich.